good evening. I'm Melissa Idris. You're watching Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. Hepatitis is said to be a silent disease, as the huge majority of those infected are not aware of their status and are often show no symptoms of the disease and therefore don't seek treatment until it's too late. Now, 2/3 of all liver cancer deaths worldwide are caused by hepatitis B and C. And if nothing is done to combat hepatitis, by 2040, it is expected to have caused more deaths than HIV, TB, and malaria combined. The WHO has already set the ambitious target of eliminating hepatitis by 2030. And this means a 90% reduction in all new cases of hepatitis B and C infections by the end of this decade. So is Malaysia on track? Let's find out more. We have joining us on the show tonight Dr. Rosaida Haji Mat Syed. She's the National Deputy Head of Gastroenterology and Hepatology Services at the Ministry of Health. She's also the head of the medical department at Hospital Serdang. Dr. Rosaida, thank you so much for joining us on the show today. I'm hoping you can begin our conversation by helping us understand what is the current burden of viral hepatitis in Malaysia. I'm just wondering whether we've been seeing an uptrend. Has this disease been on the uptrend in the past few years?
Okay, currently, it has been quoted that Malaysia is a country of medium seroprevalence of hepatitis B virus in general population, and the prevalence ranges from 1.5 to 9.8%, and estimated about 1 million people chronically infected with hepatitis B in Malaysia, and 75% of all the viral hepatitis cases are due to hepatitis B infection. And most of these carriers are infected prenatally owing to the high viral load in Malaysian women of childbearing age. And hepatitis B incidence in Malaysia demonstrated a steady decrease from 1990 to 1997 due to the universal vaccination program in infants, which commenced in 1989, and various control program. And in 1998, however, there's a sharp increase in reported cases was noted due to the inclusion of mandatory testing of all foreign workers who had arrived in Malaysia. The decreased trend from after year 2000, which rose again from year 2010, as a government has implemented the rule that all cases of hepatitis B should be reported. And in 2009, an estimated of 2.5% or 453,700 people were living with hepatitis C in Malaysia. The prevalence among males is much higher compared to female. And in terms of ethnicity, prevalence among the Malays male are much higher, as high as 84% compared to the Chinese and Indian in ethnicity. The main mode of transmission and hepatitis C virus transmission is due to the parenteral drug use, which occur in 85%, transfusion in 3%, and dialysis. However, based on the Muhammad N.A. et al. Study in 2020, the prevalence of hepatitis B surface antigen among Malaysian adult population was only 4%, whereas approximately 0.3% of the adult population in Malaysia are living with hepatitis C virus infection.
Okay, all right.
So it looks like the prevalence of hepatitis B and C are coming down actually, and we might able to eliminate and and achieve our target by year 2030.
Well, that's fantastic news, and it seems that there is a lot of data, a lot of research being kind of funneled into looking at how the disease spreads and how best to track and treat this disease. Let's talk a little bit about one of the things that I mentioned a bit earlier, and what I have come across in some of my research is that it's often been referred to as a silent disease, and that's because so many people are not diagnosed. Can we talk about that? Whether, the reasons for why so many people live with viral hepatitis yet are unaware of their diagnosis. Why do so few people get tested for hepatitis?
Okay, most of the hepatitis B and C virus are asymptomatic, and about 90% of the patients infected with hepatitis C are unaware because they have the virus that makes them, they are unaware that they have the virus that make them a healthy carrier. So far, we have actually do a massive screening. We encourage. So it's important for the the population knows who are at risk and those are at risk to be screened. This include the people who are use or inject drugs, intranasal illicit drug use, and people who have blood transfusion, blood product or organ donation before June 1992, person who living with HIV, especially those MSM or men who have ever had sex with men, multiple sexual partner or transgender, and those who ever had incarcerated will be very high risk, okay, to have the hepatitis C. And children born to hepatitis B or C infected women, partner of hepatitis B and C positive status, patients who are on long-term hemodialysis, and those who have unexplained chronic liver disease or just elevated liver function. So those who have been successful being treated for hepatitis C and still continue his or high risk behavior, hepatitis C screening should be encouraged yearly. So they should continue screening yearly.
Okay, so it should be a yearly thing for those who are considered high risk. But do you think that this should be universal? Because the way you described who is considered high risk for hepatitis, it seems that if you think that you don't do these, you're not a drug user or I guess are incarcerated. I think some things that you mentioned, you think that you're not at risk for hepatitis. Do you think that hepatitis should be made universal testing, that everyone should be tested for hepatitis, even if you don't fall into a high risk category?
Okay, we have previously we have done a World Hepatitis Day to find the missing million. But when we screen as a general population, the prevalence is very, very low actually. That's why in this year, in World Hepatitis Day for 2022, we more of screening at the targeted area. That means we screen at the prisons, more of prisons, the Felda settlement, fishing villages, and also at the maybe at the AADK. That means where the AADK, and also among the refugee camps where we know that the risk of Hep B and Hep C is there, and there will be higher positive rate.
Right.
So this
it's a
is more of
risk.
cost effective rather than
I see. It's a risk-based
risk
strategy
targeted.
of.
Yes, rather than screening overall, with the prevalence very low, and this is more for cost effectiveness for Malaysia.
Doctor, you mentioned just now that prenatal infections was also a consideration in women who didn't realize they were are hepatitis carriers, and then they pass it on to their unborn children. Well, how is that being does that have a different approach to testing or to eliminate this type of transmissions for hepatitis? Is it different in the way you approach this?
Okay, this is very common, important, because the commonest mode of transmission in Malaysia, definitely we know is through mother-to-child transmission. That means which may occur during either utero or perinatally. Therefore, antiviral agents such as lamivudine or tenofovir, high viremia, is to prevent this mother-to-child transmission of this viral hepatitis B. In fact, when the baby is born, we also will give immunoglobulin and first dose of hepatitis B vaccine within the 24 hours of birth, as to prevent this transmission of the virus from mother to child. So that is the way that is the strategy that we have done, that to reduce the prevalence of a new infection of hepatitis B among the newborn.
Okay, I know you have been working in this field for a very long time, Doctor. You know, you've become a real leading voice in the field of gastroenterology and hepatology. Can I ask you, in the time that you've been working on this, dealing with patients and also communities, have you seen public attitudes change, particularly because it seems that there are certain risks associated with hepatitis that may also be deemed, be stigmatized in society? Have public attitudes changed, Doctor?
So far, we can see that we have working very hard about this, but this is the issue that our public has not very concerned about the risk, and continue with the high risk behavior. And this is what we need to strategize and to educate our public. So we are active, medical, Minister of Health is actively working on it to educate more to the public. But we have many CSOs, civil organization, the NGOs to help us to educate the public regarding the disease, the risk, and to come forward to screening and to also to be treated, and what are the prevention should be taken to get reinfected once successfully been treated.
Okay, all right, let's come back to that and continue our conversation about this. We're going to take a quick break here and consider this, but we will be back, so stay tuned. Hi, thanks so much for staying with Consider This. I'm Melissa Idris. Let's continue our conversation with Dr. Rosaida Hajimat Syed. She is a senior consultant physician, specializes in gastroenterology and hepatology under the Ministry of Health. We're discussing the underappreciated global public health issue of eliminating viral hepatitis and the tools that are needed to test and treat and cure hepatitis. Let's talk a little bit about treatment, Dr. Rosaida. I understand a year ago, Malaysia made an affordable and effective oral care for cure for hepatitis C available or registered in Malaysia. Can you tell us a little bit about what that was, how groundbreaking that was for Malaysia to do this?
Okay. This is an initiation by the Drug for Neglected Disease Initiative, a non-profit organization which cooperate with the Ministry of Health. They brought in a phase 2 and 3 trial on treatment of chronic hepatitis C using the sofosbuvir and ravidazole in Malaysia and Thailand. So we have 2 stages in that trial. The first stage was performed from year 2017 to 2019, and the overall SBR12 rate in intention to treat analysis was 97%, which is very good. Following that, on the 4th June of 2021, Malaysia has become the first country to grant conditional approval for Ravida by Malaysian drug control authorities based on the phase 1 study result. So we continued the phase 2 trial, which have completed last year in 2021, and we can see that overall SBR12 rate for intention to treat analysis was 96.8%. Currently, Pharmaniaga is planning to get the full registration for the Ravida. But on top of that, we already have our national treatment program. We're using the sofosbuvir and daclazazvir in the 44 hospital and more than 300 health clinic currently. So depends on the status of the liver, the patient's liver status, that means cirrhotic or non-cirrhotic, and the type of genotype the patient has, then treatment can be given under 12 weeks to 24 weeks. And reassessment of the viral load at 12 weeks after completion of treatment showed that more than 95% of those being infected has successfully been treated. So it's a good news for us because hepatitis C is curable now in Malaysia.
Is there a possibility of reinfection once cured?
Yes, there's possibility if the patient still continue his or her habit. So that's why despite the hepatitis C can be treated and successfully being treated, but if they continue using sharing needles and so on, unsafe sex, then they can get infected back. But by saying that, we can also give the second line of treatment to treat the hepatitis C, which being infected again to the patients.
Right. I understand that part of the success that we're seeing with the downtrending of hepatitis cases, viral hepatitis cases, was because Malaysia launched a plan. So, in response to the WHO target to eliminate hepatitis, Malaysia responded and said, okay, we need a national plan, as a 5-year plan. And one of the things that happened was really to work with civil society organizations and kind of decentralize the approach. Can you talk a little bit about that, the importance of decentralizing the testing, treating, and curing hepatitis, not just at a federal level, but down to the klinik kesihatan level?
Okay. Initially, we started in 1997 to treat at the hospital level only. Because we just started with the DAAs, we brought in the sofosbuvir and daclazavir. So first we treated in 24 hospital. After 3 months, we expanded furthermore to more than 30 hospital. After that, the next year in 1998, we started to decentralize to 25 hospital together with a FIND study. In this study, actually, we test using the rapid diagnostic test kit, which was donated 1,800 kits donated by the FIND company. And from there, those who are positive will be sent to hospital for confirmation, and following that, we treated either with using our national treatment program within Sofos and daclazavir, or we recruit in the DNDI study with the ravidasvir. So after that's been successfully, after we completed that study, we see that's successfully being treated, and we know that we could decentralize further, because many patients with this, especially PWID, person with injecting drug, they're not keen to come to the hospital. They rather to stay at their own health clinic. So because of that, we expanded the from 25 further to until 40, more than initially 44. After that, we increased to more than 300 now. So basically, wherever they are, they can be treated. No need to come to the hospital anymore.
And how did you come to this conclusion? I think that it's so important to collaborate between different levels of government, but also with civil society to really target, because hepatitis is so risk-based, you need to target the high-risk communities. How did you work with, how did the Ministry of Health work with prisons, with detention centers, with communities that are considered high risk? What was the thinking in terms of the approach for education about this disease, about awareness of the disease, and the need to screen and test regularly?
Okay, one of the thing that we educate our CSO, okay, and they will bring all the patients to us, and because CSO have very close connection with all the PWIP actually, so they will actually encourage them and advise them to come forward. And regarding the prisons, we will communicating with the prisons departments now to actively going into the prison in all states, basically. So because majority who are incarcerated, actually most of them are hepatitis B or hepatitis C, having a hepatitis C infection. So what we'll do now is, once they are positive, we will give the treatment to the patient in the prison itself. It's the best way to treat the patient, because they will be in the prison and we will give them as adults, something like that. That means the doctors in the prison will make sure the treatment is given every day within the 12 weeks or 24 weeks of treatment only. So with that, we can achieve a good successful rate for this patient in the prisons.
I was just wondering, so prisons, because you have patients there, maybe direct access to the medical officer on site. Are there communities that may find it difficult to be linked to care or to reach the care that they need? Are there communities with limited access, perhaps key populations that are at high risk of hepatitis that may not have access to treatment? Are there efforts to overcome those barriers?
Okay, currently what we can see that is the fishermen villages and the Felda settlement, which have been a bit lag behind, and they have not come forward. So what we'll do now with this current World Hepatitis Day, in conjunction with our World Hepatitis Day in 2022, we decided that all states AIDS officer and including the PKD, pejabat kesihatan daerah, will go down and start to have the outreach program to this settlement and also the villages. So this is our target program for this year. So we have many already done the program, and many also planning to do in August and September. Hopefully, we can get more of patients being infected who have not been diagnosed and come forward and for treatment. So in fact, what we'll do is we go down to them and get them treated and to screen them.
What a fantastic approach to really bringing down, to really connecting communities with treatment. Dr. Rosaida, thank you so much for being on the show with me tonight and sharing some of the important work being done on this very pressing public health issue. Thank you for your time. That was my conversation with Dr. Rosaida Haji Mat Said, Senior Consultant Physician specializing in gastroenterology and hepatology under the Ministry of Health, wrapping up this episode of Consider This. I'm Melissa Idris, signing off for the evening. Thank you so much for watching, and good night.